Добрый день, дорогие друзья. Я думаю, мы будем начинать. В первую очередь, безусловно, хотел бы поблагодарить.
I believe it's high time we start. First of all, let me please thank the Moscow government and Department for Healthcare for taking part in this healthcare conference. This session is focused on HIV. You all understand how important and topical this issue is. Despite all of the progress achieved, it is still a burning issue. In many regions across Russia, we see increasing rates of HIV. Some progress has been made in developing an HIV vaccine, and at the Institute of Immunology that I had, we also have had a project to develop an HIV vaccine. We made it to phase 1 of clinical trials, but unfortunately, due to the lack of funding, we had to stop our efforts. Lately, some significant progress has been made in HIV management and treatment, but despite this, HIV is unique. It is able to penetrate in virtually every part of the human system and to infect it. That is why, in order to provide high-quality treatment to our patient, we should be able to diagnose it as soon as possible and not to let it damage the whole system. That is why I believe our today's session will be very important for clinical researchers and for GPs who should be able to see HIV for what it is and to be able to diagnose HIV and to help HIV positive people. Indeed, I'm sure that our today's session will be most substantive. We have leading experts joining us today. It is a great pleasure for me to introduce our first speaker, Eugen Rockstraw, Professor of Medicine and Head of the HIV Outpatient Clinic at the University of Bonn. Please, Professor, you have the floor. Hello, my Russian leaves much to be desired.
To continue in English. So my task today is talk about the differential diagnosis. When do we need to think of HIV, in what setting, so that we don't miss the diagnosis? So let me start with the patient case. And this is a real case. So a 32-year-old man presents in the emergency room with fever, cervical lymph node enlargement, and a rash after a 1-week trip to Ibiza, which is a Spanish island where you go out and party all the time. And this is his torso upon clinical presentation, and you can see the rash, which obviously is something you also see in conjunction with all kind of different viral infections, and probably one of the differential diagnoses would be mononucleosis. But what is very important in this context is, so if someone has been away for a week, presents with these symptoms, is obviously, what is the clue, is not to forget to take a sexual history. And I think that's one of the things which is very difficult, because we as physicians are not trained to ask these questions. It's always a question of intimacy. Do people want to talk about it? But if we don't understand what's happening and what sexual history there is, we may miss essential diagnosis. And one other example of that, this is a different patient of mine who presented with a very subtle rash where you only saw changes on the palmar sides of his hands. Now, for an HIV physician, I see Elena is already nodding, you automatically think of syphilis. But believe me that this patient was at the dermatologist and he did not know what it was. So I think, and obviously you have to ask this history And if it turns out that he has multiple sex partners, unsafe sex, you will understand that syphilis is a likely scenario. And if syphilis is in the game, then obviously making an HIV test is very, very important. So acute HIV infection can be symptomatic in 40 to 90% of cases in literature. So very often people do not experience clear symptoms, but fever, a rash, oral ulcerations, and cervical lymph node enlargement, together with potentially joint pain, pain when you swallow, and fatigue are very clinical, typical symptoms of HIV, of acute HIV infection. And indeed, today, someone who presents with acute HIV infection, you would immediately start HIV therapy to minimize the reservoir, as we believe if you shut off replication early, not all of the cells in the gut become infected, and if there ever should be a cure strategy, this patient would be prone for early intervention. Now, one of the diagnostic challenges in early HIV infection is that the typical HIV ELISA, the antibody test, can still be negative. That's what we call the window period. So in order for an immune system to produce or develop antibodies, some time may go. So in this particular case, when I did the HIV antibody test, because it was cheaper, the test came back negative. But because of high suspicion and further lab tests showing that he had a past EBV infection, I ordered a PCR which turned out to be positive. So in that case, when you have a high suspicion of acute HIV infection, you really need to think of doing a PCR to confirm acute seroconversion. This is some examples of the aftus or ulcers you can see upon seroconversion, so they can be quite mean and hurtful, also in the esophagus, but mostly in the mucosa of the mouth. As already alluded to, although the modern fourth generation antigen antibody tests, so there's also P24 in there, detect HIV earlier, there still can be a period of up to 2 weeks where the antibody test may be negative, and at that time point, an HIV RNA will be helpful to confirm HIV acute infection. Now, one of the important things to say, if you do regular HIV antibody testing, remember that this diagnosis is different than diabetes or a cancer. It can be very stigmatizing, so always be respectful and careful of what you're transporting as a message, and also be well aware that the antibody test was developed to make sure that everyone who has HIV gets detected. So the sensitivity of the ELISA is high, but the specificity is low. So that means you can have a false positive HIV ELISA test in the setting of a stimulated immune system. It could be in the setting of pregnancy, for example, could be in the presence of autoimmune disease and cross-reactive autoantibodies or immune complexes, could also be after other infections or vaccinations. And I remember I saw a lady who started to work in a German university hospital, just married a German surgeon, and her HIV test came back positive, and she came to my center, and in further workup it turned out that she had acute EBV infection, and that has a cross-reactivity with the P24 antigen band, and so in the end she didn't have HIV. So always important to remember that this test can be false positive, so be careful and confirm diagnosis before making the definite diagnosis of HIV. Whoops. Now, the other big issues, others than the issues around very early diagnosis during seroconversion, is obviously late presentation. So many patients present very late in their HIV infection, and many reasons contribute to that. It may be that people just don't feel that they are at risk. It may be that people don't really want to know because they're scared of the diagnosis. It may be that there's stigma around going to a test. So in order to compare countries and epidemiological studies, there was a strong need for developing a consensus definition of late presentation. And at that time, in 2011, the common definition was anyone who presents with a CD4 count below 350 at initial diagnosis or already has developed AIDS is considered a late presenter. And the reason for that was that at that time, guidelines recommended HIV therapy at the CD4 count of 350, so anyone who sort of had a lower CD4 count would have missed the time point of treatment initiation. And what you can see here from the ECDC WHO figure is that indeed patients who present late are very, very high. It's almost 50% of all patients. You can see it's higher in women than in men. You can also see that it's higher in older age groups. And you can also see that it is higher in the Eastern European region and in Africa. And again, I think a lot is around stigmatization. In Africa in particular, having HIV means that you may be closed from your own society, and so people are very reluctant to go to a test unless they feel actual clinical symptoms. Now, with regard to women, I think it's important to note that most of these women are in their 40s, and most of them were diagnosed at a late stage of HIV infection. 2/3 of the HIV diagnosed among women in 2018 were in the age group 30 to 49. Heterosexual was the most common HIV transmission mode. And I think in this group, we commonly don't think that a woman does have HIV. And there is no question around sexual practices or partners. And that's one of the reasons why this diagnosis is really missed quite frequently. And clearly we need to do better in diagnosing HIV in women in particular. And the WHO regional director stated, late diagnosis in women indicates that gender-sensitive counseling and testing, including information about sexual health, is not reaching this population. It's time to end the silence about sexual health, especially when it comes to HIV, and ensure that women are well informed and able to protect themselves. If we are to achieve universal health coverage, we need to improve prevention, treatment, and care for women, and reduce missed opportunities for testing those vulnerable to HIV in health facilities and in the community. So I think this is a big pledge, particularly for the female individuals. Now, one of the alarming issues around late presentation is if you look at large cohorts and look at different exposure groups over time, you can see that the amount of patients who present late does not change by observation period. So really, although we have implemented many strategies to prevent late presentation, not so much is changing, which I think reflects the fact that the reasons why patients present late have not changed altogether. And again, stigma probably being the biggest reason for people not going to an HIV test. So what are the consequences of starting late? Well, you have a higher risk of dying from HIV in the first year. Your probability of getting suppressed under ARV or antiviral therapy is lower. There's a higher risk of being admitted to the hospital. There's a higher risk of drug-drug interactions because you have complex drug regimens you need to take when you also have opportunistic infections. You are more likely to have immune reconstitution syndrome, which can lead to severe disease manifestations. And in the long term, you have an increased risk of non-AIDS events, in particular cardiovascular risk events, because of the long period of inflammation when HIV was already present. Also, the risk of cancer development is increased. There's a higher risk of neurocognitive impairment. Remember that HIV can infect cells of the brain. There's obviously, in the period of undiagnosed HIV, an increased risk of HIV transmission, and there is a much higher cost of care. So also from the society economic standpoint, it would be much better and more desirable to diagnose patients early. Now, in order to change that, the European AIDS Society and HIV Europe, which is now called HIV Test, have worked together to really try to come up with indicator diseases where we would recommend HIV testing. And the issue is obviously that if you go to a medical society and say everyone with a lymphoma should be tested, they're going to say, is that cost effective? Do we really need to test everyone for HIV? So this group of individuals felt that it was worthwhile to conduct a study, which was called HIDES-1, and looked at indicator diseases across Europe. So in many different, over 15 countries, we looked at patients who were not in HIV clinics, but in STD clinics, oncology clinics, hepatology clinics, and so forth, and tested anyone who presented with a sexually transmitted infection, lymphoma, cervical or anal dysplasia or cancer, herpes zoster, hepatitis B or C, ongoing mononucleosis-like illness, or unexplained thrombopenia or seborrheic dermatitis. And we believe that if the prevalence is above 0.1%, that it would be cost effective to offer HIV tests in any individual who presents with any one of those clinical conditions. And you can see that the prevalences range from 0.29 for lymphoma all the way up to 4.06 for sexually transmitted infections. So really all these diseases, if someone would see a patient presenting with that kind of condition, it would make sense to sort of perform an HIV test. And this was really true for all the different regions in which these tests were offered. So the European AIDS Society has developed a list of indicator diseases, which you see listed here, where we say in the setting of a patient presenting with any of those diseases on the left-hand side, it would really be cost effective to perform an HIV test. We also believe that there are other conditions where it would be cost effective, but we didn't have the data to really show that. So subsequently, a second study was performed, HIDES-2, more recently, again looking at the cost effectiveness of offering an HIV test to certain specific indicator conditions. And this time we also included pneumonia, for example, unexplained lymphadenopathy, and both of them were highly prevalent, and again, it seems cost-effective to perform tests under these two conditions. So now we have a whole list of different conditions where we should think of it. And I can tell you in clinical practice, one of the often missed opportunities is oral candidiasis. So if you have oral candida in your mouth, as a physician, you really have to ask 3 questions. Did you have a prior antibiotic treatment? Because that can also lead to a change in the flora of your mouth. Or do you have diabetes? Or did you receive chemotherapy? If there's a no to all of these 3, then immunodeficiency, including HIV, becomes a very likely opportunity to perform an HIV test. So that's very, very important. And you should know that many of the patients we see with these specific conditions where I'm showing you the corresponding clinical pictures have been seeing 2 or 3 physicians before they see us and we do the HIV test. And really one of the most common features of HIV infection is a herpes zoster infection. And I would say that almost a third, if not a half, of all patients I see with newly diagnosed HIV, if you ask, did you ever have an episode of herpes zoster, an episode of shingles, they're going to say yes. And no one ever treated or performed an HIV test in that patient. And it's just because the physician doesn't want to ask the question of the questions, right? Does not want to take a sexual history. So it's really a lot of missing. But if you have a 27-year-old young man, why should he have herpes zoster? Unless he's in a very stressful situation, has lost his partner or his parents, or something traumatic happened. It's very unlikely to develop that outside of the setting of immunodeficiency. So if you don't have a cancer, you don't have diabetes, you have to think of HIV as a possible underlying cause of this infection. Sometimes we see people who are referred by the dentist or the ear, nose, throat doctors because they see this white change mostly along the tongue, which is called oral hairy leukoplakia. It is EBV mediated, and in contrast to Candida, which you can brush off, so that's the big differential diagnosis. Candida you can always brush off and you have it on your swab, but this is not off-brushable. Patients complain of taste disturbances. It feels kind of weird. It may even be painful. Again, this is something which is highly suggestive of HIV infection, and you should consider testing for HIV. Now, seborrheic dermatitis is very common. If you are a doctor and you have done your residency and done night shifts, everyone develops a seborrheic dermatitis after 25 night shifts in 1 month. So we have to be fair. This is something you often see in stressful working environments, a lot of night work. But in this picture, you see a very extreme form. So if it gets very extreme, please also think of HIV infection, which is a common reason for more extensive presentation of seborrheic dermatitis and should also prompt an HIV test. And you can already see in the mouth ends that there is redness and soreness and probably has Candida infection already as well. Another important feature, and that brings us back to, I think, in modern medicine, physical examination is getting less and less popular because we leave everything to big diagnostic machinery, but actually doing a physical examination and looking for lymph node enlargements is very important. In the setting of lymph node enlargement, you also have to consider HIV. Remember that in the Hyde study, this was something which was associated with an HIV infection, so also think of HIV in this context. Obviously, there are differential diagnoses, should be tuberculosis or lymphoma as the most prominent other causes of rapid progressive lymphadenopathy. Unexplained thrombocytopenia is also a cost-effective reason for HIV testing. This is a patient who had HIV-associated thrombocytopenia, so very rarely does it lead to bleeding events, but it can happen. And I have to say that in our hospital, there was one patient who did not have an HIV test in the setting of low platelets, and he subsequently sued the hospital, and the hospital lost the case. So if you have unexplained thrombocytopenia, thinking of HIV is a very important differential diagnosis and actually not that uncommon. So this is, I think, another important feature of HIV, and obviously you can see cutaneous Kaposi sarcoma on the left-hand side and then an oral manifestation. The patient on the right was referred to me by the dentist. So again, if the dentist sees someone like that, he should think of HIV and send the patient correspondingly. And the other patient with the cutaneous manifestations remembers me of one patient I had, and it tells you a little bit how difficult it can be to offer an HIV test. So this was a Greek man who developed severe cutaneous KS with a swollen face. And his dermatologist said, well, you're older Greek men, and this is a tumor which also affects Mediterranean men at a certain age, so maybe this is because you're from Greece and so forth. What he did not ask him was, what do you do sexually? And it turned out it was a man who had sex with men, and so he missed the opportunity of doing an HIV test. But the patient also just simply did not want to know. He knew he was at risk, but he didn't want to know. So dermatologist and HIV patient both agreed this was a KS from an endemic Mediterranean country. Then he came to my clinic, and I've hardly seen such a swollen face, one big tumor, and obviously the HIV test was positive, and we started HIV therapy and did chemotherapy, and fortunately he lost all the KS, it all disappeared under chemotherapy and antiviral therapy. But it tells you how wide people are ready to go to deny a diagnosis. So it's really important to keep in mind that certain entities like KS are very rarely seen outside of the context of HIV today and should be a reason for offering an HIV test. One other important clinical condition is cerebral toxoplasmosis. Now, cerebral toxoplasmosis is an AIDS-defining event, so it occurs very late in the onset of HIV. It is something which can also affect other organs. You can also have a toxoplasmosis retinitis and other features, but very commonly patients present with seizures. That's the most common first manifestation. So out of so far relatively normal health, patients suddenly present neurologic symptoms, mostly in conjunction with seizures. Then an imaging is done, MRI or CT scan, and then you start seeing focal lesions like you see here on the MRI. And then even in that setting, people do not think of an HIV test, because the last one we had was a guy who had give driving lessons for cars. He was married, had 2 children, and was 64 years old. And people don't think that people with 64 still have active sex and get HIV infection. And I think it's just misunderstanding how the world is. So it was very important to think of that, because usually in the German setting, if you have a lesion like that, the neurosurgeons are going to say you have a focal lesion, it's probably a tumor, we're going to do a biopsy. And obviously, if you would do an HIV test, you would think of toxoplasmosis. So this is a common situation. We still see that neurosurgeons or neurologists forget to do the HIV tests, and that always is obviously a big issue. So there are many clinical conditions where you should think of HIV, and I hope I showed you some of the signature clinical manifestations. So there's clearly room for improving testing strategies. I think stigma-free testing options are the most important to help increase diagnosis rate, because most of the people who have been seen by physicians prior to their initial HIV diagnosis did not think of it, or the patient didn't want to think of it as well. Indicator condition-guided testing is clearly a cost-effective testing strategy, and you saw the list of clinical conditions where it makes sense to test for HIV, and really we have to work that all other medical societies implement that. So we have to talk to the gynecologist, the neurologist, the dermatologist, and so forth, to make sure that they capture HIV testing in the presence of indicator conditions. Late presentation is obviously very detrimental for the affected individual. It increases patient morbidity and mortality. It clearly is also bad for the society because it increases healthcare costs and prolongs the time where onward transmission can happen. So clearly, earlier diagnosis also means reducing the risk of new infections. Don't forget that patients who present late actually still die from late presentation. 4 to 6% experience serious disease or die. And it clearly limits the effectiveness of all subsequent steps in the cascade of care. So with that, I'll thank you all for your attention. Thank you.
Уважаемый профессор Рокштуб, большое спасибо за такой...
Thank you, Professor, for this very informative presentation. It's quite obvious from your talk that early diagnosis, early detection is very important to start the therapy early, to control the virus, to reduce the viral load. This will help us control infection with the patient and stop the further spread. But here's my question. What do we need? What are the measures that we need to take for early presentation? How can we improve the efficiency of early presentation and detection?
I have to say that is a very difficult task. And when I became president of the German AIDS Society, 10 years ago, and we already had the problem of late presentation, and we really tried very hard to change that in Germany, which meant that we went to all kind of medical society meetings. When the gynecologists met, the dermatologists met, we wrote articles, review articles of when to think of HIV, went to their meetings, spoke about early diagnosis, and it changed absolutely nothing. And the problem for that is that people who don't want to get tested, it's very difficult to reach. And I think what really changed was the introduction of community-based testing. So people don't want to go to a hospital. They don't want to go to a public health service because they think that is the state, that it's documented, it has consequences. So the introduction of community-based testing has really helped to get at-risk populations, at least to a certain degree, into testing. I think that the fact that we, since September last year, have free pre-exposure prophylaxis, and you only can get pre-exposure prophylaxis if you get tested regularly, has really helped to make a change, because now people are getting more often tested. But I think there are people still so afraid, although they know that they are at risk, but they're so afraid that it is just very difficult to reach them. And I can tell you that for that reason, in Germany, the first 90, so our 90% patients diagnosed, no, it's only 88%, because we're really struggling to get those missing 12,000 patients to be tested. And that is a remaining struggle. And I think it really needs the help of everyone involved to make the entire push. But you can see that countries like United Kingdom, who just announced today publicly that they have a 73% reduction in new diagnosis, and they have 95% of all patients diagnosed. And you wonder, so what are they doing different than the Germans? Because why is it that they can test everyone? And I think it has a lot to do that they have much better STD clinics. Like in Germany, we don't have good STD clinics. So if you have, let's say you had unsafe sex, you think you may have a syphilis, dermatologists don't want to deal with that. They rather want to give Botox injections. It's not, it's a problem, because where do you go and can you speak about it? And the English service environment is a little bit more oriented to STD screening, which obviously is very helpful in the context of diagnosing HIV infection. So I think there are countries where we can learn from.
Большое спасибо. Коллеги,
All right, let's see if we have any questions. Distinguished professor, my phone keeps ringing. I collect all questions for our experts. Do you do additional training devoted to HIV infections for general practitioners in Europe?
So what we do, so we have a journal which is sent to every physician once a week in Germany, for example. And in that context, we publish like an article on when to think of HIV, what does HIV look like, what are typical clinical conditions. So that's one way. We encourage to have sessions when general practitioners meet in their annual meetings to have an overview of HIV and by now also hepatitis and STDs. And a lot is also about the fear of issues around the budget. So the general practitioner in Germany only has a limited budget for lab examination, so that's another hesitation. And so we're fighting that there's full reimbursement so he does not have to worry about money in his budget. But it is a struggle, because the general practitioner, we're asking a lot. He has to think of diabetes, hypertension, cardiovascular screening, colon cancer screening, HIV, and sometimes I think for these poor people it's a lot. And they have 150 people in the winter time coughing and sneezing, and then they still have to think of HIV. So it is a challenge, no?
коллеги, если
If there are no more questions, we'll move on to our next presenter, and that is Helen Tsiganova, head of the Scientific and Clinical Department of the Moscow City AIDS Center, clinical examples of mass HIV infections. Distinguished colleagues, allow me to present to you a presentation also devoted to masks of HIV infections. Please help me with the presentation. It is true that today, and we're trying to find the right presentation. Professor Rockstro and I have a lot in common in terms of what we think. My presentation will be more about clinical cases, examples, and I will start with the clinical course of HIV infection, the classical path. And here you see the periods where we can register the manifestations of HIV infection in our patient. And I quite agree with Professor Rockstro with regards to correct collection of history from our patient, what we registered. Maybe the patient already came with a certain history of their illnesses. Let me give you an example. Yesterday, I discussed it with our colleagues. A few years ago, a patient came to us, a young woman of 30 years of age. She plays cello professionally. She used to go on tours. And her first question was, when she came to me, please give me a medical certificate that I have HIV and that I can get surgery to remove the tumor of lungs. I looked at her history as they taught us in medical university. I find out that in 10 years before this patient came to me, she got back from her tour. She was covered with lesion with rash from top to bottom. She realized all the risks of her life. She went to dermatologists and venereologists, but she got tested 3 years ago. 3 days ago, rash went away. She went to another tour, and the patient forgot that she even had this problem. The patient said that she got a phone call from the dermatologist, and she invited her for a consultation, saying that the analysis of the tests are not, the results of the tests are not good. It's not recommended to say something like that on the phone. And the patient made a decision not to get back to that dermatologist because the rash had gone away. And 10 years later, and the patient gets to oncologists with the suspicion of lung cancer. Knowing this story of her life, that this was tuberculosis, classical painting when the top of the lung was affected, but back then the patient was really scared and she forgot about what happened 10 years ago. We could have treated her for 10 years. She is fine now. Of course, they dealt with her TB. They prescribed antiviral, retroviral therapy, but our patients are not always adequate as they assess the conditions that they have. Acute HIV infection, from the moment of infection until antibodies are detected, then RNA HIV until antibodies, and the short period of clinical manifestations of HIV infection against the background of high viral load. In our hospital, we sometimes see a very acute stage of the HIV infection with obvious clinical 10 million viral load in the blood serum, but no antibodies. We have to convince the patient to keep study and immediately start the antiretroviral therapy. Professor already mentioned that. Acute retroviral syndrome. What do we need to consider here? In almost 100% of cases, they have extreme fever. Lymphoadenopathy is another symptom, most common symptom. Pharyngitis and rash or lesion is registered in 70% of cases. This rash disappears without special treatment in 3 days or maybe 2 weeks. Sometimes they get diagnosed with allergic dermatitis and don't offer them to get a test for HIV antibodies. Please remember about this when you consult such patients next time. Right, during the acute period, sometimes only the viral load allows us to diagnose the HIV infection. The patient may not even have antibodies. The latent studies or subclinical studies, it is believed that during this stage the patient may not have symptoms, but very often the only symptom at this stage is the enlarged lymph nodes, and so we can offer patients to get tested. Secondary morbidities have obvious clinical symptoms. You get all your skin and mucous membranes and gastrointestinal tract and breathing and your urinary system. They all get damaged, especially if patients are not careful about their health and they don't get antiretroviral therapy. Sarcoma, Kaposi sarcoma is what really helps us diagnose HIV infection. Of course, if you get this kind of signs, that you will come to a doctor, and this is how it could also look like. This is differential diagnostics for a multidisciplinary team, because you need differential diagnostics with cancer and TB.
Candidiasis and indeed is a very important indicator, and Professor Rockstra has been speaking about that already. Let's take this example. A male patient of 34 years of age, approximately. Let me give you his background, the background of this case. Back in 2011, my colleague approached me and asked me to consult a patient. She was diagnosed with HIV infection, but looking at family history, it would be more logical to suspect that her husband had HIV, because he was a drug user, and he also suffered from hepatitis C virus. We started to talk to the patient, and we found out that in 2001 our patient was hospitalized with acute hepatitis. In 2 days, the patient was dismissed from the hospital, or to be more precise, the patient left the hospital. He was, as I've already mentioned, a drug user. And the patient was informed that he had B and C hepatitis. Immunoblotting test was not yet ready, so he was only aware of his hepatitis B and hepatitis C diagnosis, and he never consulted a doctor afterwards. So after that, he decided not to use drugs anymore. He married, and he openly and frankly told his wife that he had hepatitis B and hepatitis C, but he wasn't aware of his HIV, and that is why he infected his wife as well. So he then was admitted to the hospital, and he had jejunum perforation. So it was a surgical emergency. It was proved that indeed there was a jejunum perforation. The patient was frank and open about his diagnosis. He warned that he was in the past a drug user and that he had hepatitis B and C. He spent in the hospital 2 weeks, and after that he was released, and his medical record says that his HIV antibodies test wasn't yet ready, which is impossible because the hospital should have received the results within a day, within 24 hours. ELISA would show you that within a day. But due to some reason, our fellow doctors never paid attention to the fact that the HIV results of this patient never came in, and he was released, and his diagnosis was jejunum perforation plus diffuse fibrillurulent peritonitis. So we now know that the patient back in 2001 was dismissed from the hospitals 2 days prior to the actual opportunity to learn that he was HIV positive. He never learned that. In 5 days, he was once again admitted to a hospital, and he was then diagnosed with a different disease, with Crohn's disease. He was prescribed azathioprine and prednisolone. He was later on discharged from the hospital. And that is in that point in time that we met his wife, and she was diagnosed with HIV. Nobody could understand how this happened. The answer is, her husband has been HIV positive for 10 years, but he was not aware of the fact. After being diagnosed, we realized that he already had AIDS, and his GIT was badly damaged. At that point, he was admitted to surgery with cytomegalovirus infection. There was no jejunum perforation. The diagnosis, his initial diagnosis, was wrong. What other manifestations we can see? Fever, weight loss, abdominal pains, diarrhea, GIT pains. All of these are the symptoms that we should pay attention to as well. Another case, a woman, a female patient, 33 years of age. She first called in an emergency service. She had dizziness, she had headache. She was never hospitalized. Paramedics just prescribed her some pills because nobody's going to hospitalize a young woman because of a headache. On the next day, she once again called in. She had dizziness once again and headache. She was, as a result, hospitalized. It was all back in 2015. She was hospitalized. Upon admission, she was dizzy, she had a headache, she couldn't walk properly. She told the doctor that she felt dizzy for several days running, but when she was admitted to her attending physician, she only said she had dizziness for 1 day. After that, she started to feel nauseous. She was transferred to the neurology department with benign positioned dizziness, and on the 3rd day she died. She was admitted with a headache. On the 3rd day she dies. Forensics show that she had 4B stage of HIV. She had AIDS. She had cerebral toxoplasmosis. She also had encephalitis. So that is exactly what I was talking about. You, Professor Rockstraw, was speaking about theory. I now share with you some of the clinical cases. And as far as her HIV test is concerned, the result was a positive. Immunoblotting screening was also positive, but the doctors were unable to save the patient. According to our data, cerebral toxoplasmosis in 80% of the cases starts gradually. A patient feels dizzy, there is a headache, overall fatigue. In 20% of the cases, the onset is very quick. Doctors normally suspect a stroke, they hospitalize the patient, and it is quite easy to help the patient if you provide therapy on a timely basis. Indeed, toxoplasmosis also has a lot of clinical masks. There is impairment in cerebral blood circulation, impairment in central nerve system, pneumonia, and even schizophrenia. That is why I call upon all doctors, do recommend them to have an HIV antibody test. If you have a young patient, please don't hesitate to run HIV antibody test. Two more clinical examples. To your left, you see this very patient that I told you about who unfortunately passed away. And to your right, you see another female patient. She's 27 years of age, who is being treated from cerebral toxoplasmosis. Unfortunately, she is not very diligent when it came to her antiretroviral therapy, but when she learned about her toxoplasmosis, she started to adhere to her regimen very cautiously. Another example, you see to your left a female patient who received therapy, and to the right you see that she was successfully treated of toxoplasmosis using standard therapy, Funcidar, and our patients who have a very low count of CD4 cells, of course, they need prevention of reinfection to make sure they do not get reinfected. I also would like to draw your attention to the fact that in our official guidelines, it is set forth that we should recommend our patients to have HIV antibody test when they do their medical checkups, just to rule out the opportunity of having HIV. And please make sure you consult your patient before and after the test for them to have a clear understanding why they have to do this test. Because sometimes a patient may have the test, but they never come in again to learn the result. They may be HIV positive, but they never become aware of that. For us to be able to address HIV prevention, we need to make sure we establish a universal information database which will enable us to manage HIV treatment. This was something that we discussed during the plenary session. Various medical facilities should be able to exchange information in order to shorten the diagnosis period, especially when we're waiting for confirmations from other medical care facilities. If we exchange information in a timely fashion, we will very quickly have all of the test results for our patients. Services should be doctor-oriented, and indeed medical service provision should be monitored. These are the tasks that the Department for Healthcare sets for us, and indeed a mobile application would be very useful. It would come in handy because we all have mobile devices and they can be of help when it comes to our health. That will be all from me, and thank you so much for your attention. Yelena, thank you so much. Colleagues, are there any questions? Are there any comments or remarks? Mic to the speaker, please. Mic to the speaker, please. I would like to ask you the following. What about toxoplasmosis and AIDS? Can a patient have toxoplasmosis without having AIDS and have clinical symptoms without AIDS, or toxoplasmosis only manifests itself when a patient also has AIDS? If we diagnose an HIV positive person with toxoplasmosis, then toxoplasmosis indicates that there is AIDS. It means that a patient never came in to see their doctor in time, and now they have AIDS. If a patient has cerebral toxoplasmosis but no HIV, then we should look for other reasons that cause toxoplasmosis in the first place.
It'd be helpful to say that you can have toxoplasmosis. That's an acute infection. So you can have toxoplasmosis because it's an infection. Usually toxoplasmosis does not lead to cerebral manifestation, though. In the setting of AIDS, it is a patient who had toxoplasmosis in the past, and it's a reactivation because the immune system can no longer control pathogens which are in the body from past infections. So there's a big difference. The reactivation of a prior infection, and that can happen mostly in an abscess formation in the head, which is unusual for toxoplasmosis. You can have, like, I had a patient from Brazil after eating raw meat. He got a toxoplasmosis retinitis of the eye and got blind on one eye. That's a common finding, but like abscess formation of the head is not so often in the setting of immune competence. No?
Еще вопросы, пожалуйста.
Some more questions? Somebody wrote this question down. You talked about several cases where patients never waited for the results of their tests, and they only received treatment 10 years after. Can you diagnose patients quicker? That's an interesting question, but probably a person who asked this question didn't really listen carefully enough. It is not that the patients were not diagnosed for 10 years, it's that they basically left the hospital without learning their diagnosis, but the diagnosis was there. And in the case of a patient who only started to receive help 10 years after, she never learned the results of her test. She acquired her rash and she never learned the results of the test that doctors run on her. Speaking about HIV blood tests, in a day you can have your ELISA results. And as far as immunoblood screening is concerned, you only have to wait for 7 days, which is quite quick when it comes to HIV infection.
Also, a lot of rapid tests. So basically, you can also do a swab, and the test result is available within 1 to 2 hours. And it makes a huge difference because in the old setting in Germany, if you go to a public health institute, they draw blood, they say come back in a week. But in that week, many things change. You are afraid to hear the result. You get lost in the system. But in the community center, in the checkpoint, people come, do the swab, and 2 hours later, they get the result. And that's a big difference because I think linking rapidness of the diagnosis to the test is very crucial to maintain people in care.
Okay, ladies and gentlemen, we need to move on to our final presentation by Natalia Litvinova from the Moscow AIDS Center. Good afternoon, dear colleagues. Let me introduce to you an interesting clinical case. It's a patient who is a patient of our center. He is registered with us, and the presentation was translated into English by my colleague who helped me prepare this presentation, Ms. Nabiulina. And we want to listen to what Professor Rockstra has to say. It's a complicated case. It's a unique case for our center with multiple drugs resistance. It's a male, age 20 years of age, diagnosed with HIV in August 1999. After he was born, immediately, it's well known that his mother used drugs and had hepatitis C. Unfortunately for our patient, when she was tested for HIV, the result was negative. There was no prevention or prophylaxis, and she breastfeeded him because the HIV was negative. By June 1999, she got in rehabilitation center. She got tested again. HIV was diagnosed, and only then the child was tested. Antibodies were found from his mother, antibodies of his mother, and by August there was genetic material, RNA of HIV was positive, and unfortunately he got infected with HIV. And currently he has the following secondary morbidities: HIV encephalopathy, in history multiple URTIs, diarrhea, underweight. Currently, the patient is multi-drug resistant to antiretroviral, to NRTIs, NNRTIs, PIs, INIs. Other comorbidities include nephroptosis, partially duplicated right, and kidney and pineal gland cyst. And in this slide, we show the first part of that history about antiretroviral therapy to this patient. I need to say that we were shown in another presentation how antiretroviral drugs came to the market. And in that case, it was all based on financial opportunities and affordability of those drugs. And of course, it's much more difficult to treat HIV-infected children compared with adults. Not all drugs are allowed to be used for children, and you don't always have access to children dosage of antiretroviral drugs. After he was diagnosed with HIV, he got prescribed azidotimidine, the very first drug for HIV infection. The patient got monotherapy for 1 year. Unfortunately, back then, we could not really study the level of HIV RNA, but the quality test was always positive. At the age of 1.5 years in the year 2000, Zimudin, Lamudin, and Nilfinavir. Back then, he would have lots of problems with his respiratory tract, and hydronephrosis was diagnosed. Then he was hospitalized a year later, even though he got triple antiretroviral therapy. His CD4 level was going down, viral load kept changing. Since therapy was inefficient, he got immunoglobulin transfusions, and also they had to adjust antiretroviral therapy. Zidovudin was replaced by Stavudin because of nausea and vomit, and later he had similar problems with Amphelamir, NFV, and even though it worked fine before that, and then since the previous therapy was inefficient, because of those complications, it was replaced by LPV, but again he got nausea and diarrhea and vomiting, and they got back to LPV. If an adult is uncomfortable, they can try to survive it. You cannot really force a child to take drugs that lead to significant uncomfortable, unpleasant consequences. It's quite hard. But the load went up 4 times, status was halved. The patient got LPV-R, and by April 2004, the result was quite positive. The load got reduced to 95, immune status to 343 cells, 10% at the age of 6. The viral load was down under 400 copies, and the status rose to 417 cells in the microliter starting from 2006. Again, the viral load was up, and at the age of 8, we finally got the opportunity to perform the resistance test. And only at that age, unfortunately, the viral load was over 1 million copies, 263 cells in the microliter. At the moment, he received the drugs that are shown in the slide. And here we show you how this resistance test results look like. Different mutations are shown here, but not every protein mutation can lead to resistance. It's usually a combination of certain mutations. But if we see that in terms of most nucleose inhibitors of reverse transcriptase, there's a high level. There was no resistance only to tenofovir. Non-nucleoside reverse transcriptase inhibitor, you also see certain results in the slide, and nevirapine and delaverdine. And as for protease inhibitors, there was resistance to all known drugs. After we got those results, a decision was made to cancel ART, antiretroviral treatment. Most probably it was done to replace the virus in his blood by the so-called wild virus. When you cancel ART, in about a week to 16 weeks, the virus gets replaced by a wild strain of virus. It's not like a replacement. Still, the resistant strains are still there in the so-called natural reservoirs. And when you prescribe the drugs to which there is resistance, you will get viral load back in blood. In January 2008, he started to receive ABC, 3TC, and EFV. Then they added fusion inhibitor of merger for 4 months. Even though he got that therapy, the status got down to 52 cells and the load was up to 177,000. And there was a significant resistance to most niodes, no resistance to inavir, high resistance to all NNRTIs, and since protease inhibitors were cancelled, it seemed like resistance to them disappeared. This is how the results look like about his resistance. And so the patient protease inhibitor was returned, LPVR, in November, January 2008-2009, but there was no success. By January 2009, when the boy was 9, they did another resistance test that gave us no reasons for optimism. The situation remains the same. If now he even got potentially resistance to NPV, high resistance to non-nucleoside inhibitors of generation Y1, and possible resistance to generation 2, high resistance to most protease inhibitors, clopidogrel, and others, and no resistance to this new product, protease inhibitor, darunavir. Let me say again, it's really hard to select a certain regimen for children. We just try to change different regimens for the patient. In 2009, there were unpleasant consequences, diarrhea, rash. In March 2010, we stopped therapy with a status of 57 cells and a viral load of 873,000 copies. Then another resistance analysis. And if the first time when we canceled therapy, at least we removed the protease inhibitors resistance, this time it did not even happen. Let me show you once again what happened in 2009, and only no resistance to darunavir, to others possible or high resistance, and this is when we canceled therapy. Even though we canceled it, there's still no resistance to darunavir only. So nothing helped even when we cancelled ART. In April 2010, we were able to prescribe darunavir as the only drug to which there was no resistance. We selected a rather unusual regimen consisting of drugs that had some sensitivity to darunavir and possible resistance, as shown here in this slide. Again, CD4 level was 57 cells, viral load was 873,000 copies, and this approach was successful for the patient. By December 2010, for the first time, we got the viral load below detectable level of 40 copies per milliliter, and the status was up to 224 cells, and within 3 years the patient received this therapy with quite successful results. By February 2013, Viremir was back in his blood. We checked him for resistance, and we have identified the same level of resistance in the course of 3 years. He got you can say, monotherapy by darunavir, but it stopped working in 3 years. And here we show all other approaches that we used with this patient. We used integrase inhibitors that we got back then. By May 2018, he had DRVR and DTG, double dose of DTG. And because of the high viral load, this result of 130 cells and 140 copies was the best result in the last years. After that, during further studies, the viral load kept growing, CD4 went down. We tried using different drugs with possible resistance, used new Russian drug, but nothing really helped. We look here, got tested for integrase inhibitors to NRTIs and NRTIs, and we found resistance not only to what he got in the past, but to all other drugs that are not even registered in the Russian Federation. All integrase inhibitors, there's only one, darunavir, with possible resistance. The patient got tested for CCR-Phi atropism, and nunavir could not be used with him. And a few words about two other drugs that are not registered here in Russia, but supposedly he shouldn't have resistance. It's monoclonal antibodies and Trogarzo. It was approved by FDA in March 2017. This is based on monoclonal antibodies. It's used for patients with resistance of 800 milligrams every 14 days. Can have side effects as diarrhea, rash, vertigo, and vomiting. And albuvertide, the second generation of merger inhibitors, it was only registered in China in 2018. It's used for antiretroviral therapy, which is inefficient. Why do I tell you all this? Because to sum up what's happening with the patient, we had a meeting of a team of doctors, and something which is required by our bureaucracy when you have to import drugs that are not registered in the Russian Federation. We believe we will choose zidovudin, tenofovir, double dose of RTV, using other drugs shown in the slide. And albuvertide has been imported to the Russian Federation, and another drug is almost ready to get registered or to get to the Russian Federation. Thank you for your attention.
For this case, you do not need an expert because there's no advice you can really give. No? The problem is we all have these kind of patients who unfortunately came with the development of antiviral drugs. And your best treatment option was back when he failed the first generation PIs and the efavirenz, because then if you would have used darunavir with etravirine, like in the duet study at that time, rather than using efavirenz again, you would have had an option. The problem is that every time you add one active drug to resistant failing other regimens, it's just not enough. So you saw when darunavir was still fully naive, he went undetectable, but he just couldn't maintain it. And that's the problem, is that you need a little bit more. So obviously you have gone through all the NNRTIs, including duravirin, etravirin would not work anymore. You have no chance to use maraviroc, although you never use it, but in this late stage, X4 virus becomes very common, so that's a very likely event. I don't know the Chinese compound. I wonder, is there cross-resistance to other fusion inhibitors because he had T20 in the past, so you can't be sure that it's going to work necessarily. That's at least a question mark. And I think one thing to always remember is if you look at the NRTIs, you would say, why use NRTIs if he's fully resistant? But the interesting thing is that if you put selective pressure on the virus and make the virus maintain the 184V mutation, viral fitness is severely impaired. So it's just difficult for the virus to sort of replicate in the presence of the M184V. Tenofovir, although not being highly active, in the presence of certain TAM mutations, is hypersusceptible. So you always get a little bit of added activity through the 184V plus the TAM mutations. You get a little bit of tenofovir activity. So I would use the tenofovir 3TC. I wonder whether the AZT really helps because he threw up after AZT use when he was a child. So he's not going to tolerate it very well, and that's the very toxic regimen. So I would probably skip the AZT just because it's so intolerable. But I would definitely use the TDF3TC. I think the ibalizumab has very good data. 50 to 70% of patients, even those who had no other options, suppressed. So there's at least some hope. The point really is, what else can you put into the equation? And you made the decision for darunavir in the higher dose. So we know that if you have PI mutations, you can use double dose, so 600 milligrams boosted with ritonavir in the morning and the evening. And I think that's a wise idea. So I would use the PI, the 2 nukes, and the 2 options you have. But I think it's still a risky enterprise.
У меня есть вопрос.
I actually have a very, very brief question. What do you think about Trogarzo and abuvertib? Can we consider them as an option for this patient?
Absolutely. So ibalizumab, I think that if you look at the coming drugs, and ibalizumab is the one which is already licensed in the US. The problem is obviously the cost. I don't know how you're going to be able to secure the funding for the drug. I can tell you that in Germany, I have one patient very similar to this one, and I've asked for exemption to import the drug from the US, and the health insurance company says, "You are crazy!" exclamation mark. So it was declined. But we expect that Trogarzo will be licensed in April this year in Europe, and then we can prescribe it in Germany. So that would be a definite option. A lot of the patients in the Trogarzo trial also received fostemsavir. So fostemsavir is an attachment inhibitor, which is also undergoing current review with the FDA and the European agency. So that would be another promising drug. But the problem is that ViiV is not too pushy in getting this off the hook, so you never know when it's going to be. It's going to be the end of the year, and in the setting of 50 CD4 count, it's not like you have endless to wait, so that's a problem. The Chinese compound, I don't know. It's a fusion inhibitor, so my only question would be to the Chinese colleagues, does it have cross-resistance to T20? Because that's a fusion inhibitor too, and there may be protein changes, so that's something you would need to ask the Chinese colleagues, I think, up front to make sure, is this worthwhile, the investment, or is there cross-resistance?
Большое вам спасибо за...
Thank you so much for this most interesting talk. Unfortunately, it is time for us to end our discussion because the time is running out. So today we talked about HIV clinical masks, and judging from the talks that we heard, we now understand that the best way to diagnose HIV is to do it timely. I cannot but say that early diagnosis was a rule in the USSR. Akademik Zhdanov, when designing first HIV program, together with Rahim Hayatov and other experts, they determined that HIV screening is a must. And our country was the first to start mass screening for HIV. Today, Moscow does almost 5 million HIV screening tests, and we managed to detect many infected people during the first year. Unfortunately, not all of them address our center to receive treatment. We also have unique cases when a doctor orders an HIV test, they discharge a patient, then they receive the results and do nothing to make sure the patient becomes aware of the results, which is a huge mistake. And I believe that Germany is a country that was very cautious with advocating for HIV screening to its patients. And they have a unique history of HIV screening in Europe. Indeed, today such tests are a measure that is necessary to take. Moscow has made HIV screening tests a routine test, at least that is an objective, to make it a part of a medical checkup. Indeed, rapid tests are very useful for some people, but they're not a silver bullet. You know my opinion very well. Rapid tests are no replacement for high-precision tests, but they're very useful. They come in handy when it comes to self-testing, but there are many risks, especially when it comes to saliva swabs. And there are many risks as we compare them to blood work, but that's a whole different discussion. So once again, we should be very careful with our patients, we should be very sensitive, and we should make sure we inform them of the results of their HIV tests. And indeed, our discussions here today, our discussion here tomorrow of establishing a universal database, when our database will be made available for attending physicians, for GPs, will be crucial if, of course, a patient consents to that. Musa, I believe you will have a chance to wrap up our discussion. Thank you very much. Thank you very much for having me here. And I would like to thank our colleagues for their wonderful presentations. I believe we once again saw with our own eyes how topical this issue is and how crucial our joint efforts are. And thank you so much for taking part in this discussion today.